Bismillahirrahmanirrahim. In this video, we will discuss about the chronic inflammation. The references for this video are following. The learning objectives for the lecture are to define chronic inflammation and differentiate between acute and chronic inflammation, cause, duration, and cellular response, to describe the key cellular and molecular mechanism that are involved in chronic inflammation, including the role of macrophages, lymphocytes, cytokines, and inflammatory mediator. To explain the pathological consequences of chronic inflammation, including its role in fibrosis, autoimmune disease, and granuloma formation, and to discuss the relationship between chronic inflammation and its progression, particularly its link to cancer development and some chronic conditions such as atherosclerosis and metabolic disorders. We know that the acute inflammation is a sequential step. There is initiation, amplification, destruction, and termination of the process. The initiation is after the activation of soluble mediators that recruit more inflammatory cell to this environment, and depending on the extent of the injury, the process is amplified, and this process is amplified by the activation of mediators such as kinins and the complement system protein. Then the offending agent is destroyed, and this destruction is for the purpose of this destruction is to bring the process under control. There is enzymic digestion and phagocytosis that reduce or eliminate the material or infectious organism, or there is damaged tissue component that are removed as a result of we have seen as a result of leukocytic injury or the inflammatory injury. There is damage to the host tissue also. So the destruction process is associated with the engulfment removal of both the foreign particle as well as the local destructed material. Then this process should be terminated, and there is simultaneous permission to for the repair and to allow the uh, normal physiological function. So if there is extensive inflammation, a scar may also be formed. If these process, the inflammation is not terminated, this can go into chronic inflammation. So in this video, we are going to see what is chronic inflammation. Tissue response to injury is inflammation, and when this response of the tissue is of prolonged duration that covers months or weeks, in which the inflammation, tissue injury, and attempts at repair coexist in varying combination, is termed as chronic inflammation. Or it is a prolonged process in which tissue destruction and inflammation occur at the same time. Acute inflammation has got many outcomes, such as the resolution, that is the usual outcome of the acute inflammation. There can be excessive exudation. The exudate is present in excess amount that will lead to suppuration, and this will lead to the development of abscess, or this abscess can result in the formation of the scar if there is extensive injury. Then suppuration can undergo repair and organization, or excessive necrosis of the tissue if there is excessive necrosis of the tissue, that will also initiate the repair and organization of the tissue. So this repair or organization, because this is a large amount of is destructed, so this is through the process of fibrosis, or inflammation may persist and result in chronic inflammation. This chronic inflammation can also result in fibrosis and lead to development of a scar. So there are four outcomes of acute inflammation. Usual outcome, that is the resolution, then excessive exudation, excessive necrosis, or persistence of the inflammation. This persistence of the inflammation will result in chronic inflammation. So this is a table from Robbins' Basis of Pathology, and it is differentiating between the acute and chronic inflammation. The onset of acute inflammation is fast. It occurs within minutes to hours, while chronic goes on for days and weeks and months. The cellular infiltrate in acute inflammation is mainly neutrophil, polymorphonuclear, leukocytes, or neutrophil, while the chronic inflammation is associated with monocyte, macrophages, and lymphocytes. The tissue injury and extent of fibrosis in acute inflammation is usually mild and self-limited, while in chronic inflammation it is severe and going on continuously. Progressive inflammation, progressive tissue injury, and fibrosis. Local signs and symptoms of inflammation are present in acute one, while in chronic, the redness, flare are usually gone. The acute inflammation is also considered as part of innate immunity, while the adaptive immunity is linked with chronic inflammation. So this is the histopathological picture in which you can see that these are the polymorphonuclear neutrophils. These are the neutrophil, multi-lobed neutrophils that are present in acute inflammation. Multi-lobed neutrophils, nuclei, multi-lobed nuclei of the neutrophils, and these are present in acute inflammation in abundance. Many neutrophils are seen in this field, while in chronic inflammation there is predominance of the plasma cells, the large cell with this clear cytoplasm. The nucleus is eccentric toward a side, and the cytoplasm is abundant and pinkish in color. There is presence of the macrophage also. These are the large cell as compared to these one. These are large cell with central nucleus, the macrophages, and some lymphocytes are also present obviously over here. So now to differentiate between these two, the acute inflammation and chronic inflammation, the onset of acute inflammation is rapid, while the chronic inflammation is slow in onset, while the duration of this one, it is short-lived. The acute one is short-lived, while the chronic one is a long-term, takes years or weeks uh, to be terminated. Then We have seen the primary cells of the acute inflammation are neutrophil, platelet, and mast cell, while the cells of chronic inflammation are macrophages, lymphocytes, and plasma cells. The vascular changes that occur in acute inflammation are vasodilation and increased vascular permeability that results in edema, while in chronic inflammation there is development of new blood vessel, that is angiogenesis, and also there is activation of the fibroblasts that result in fibrosis. The mediators of acute inflammation are mainly histamine, prostaglandin, leukotriene, and cytokines such as interleukin-1 and tumor necrotic factor alpha, while interferons and interleukin-12 along with growth factors are the major mediators of chronic inflammation. In acute inflammation, the tissue damage is minimal and usually it is resolved, while in chronic inflammation, there is destruction of the tissue progressively and there is simultaneous attempt at repair. Then the acute one resolves completely. Sometimes there is abscess formation or it can go on to chronic form, while the chronic is the persistence of inflammation. There is development of fibrous tissue or a scar development, or there can be development of granuloma, that is the granulomatous type of the inflammation that we are going to study in chronic inflammation. Examples of acute inflammation are acute infection of the appendix, pneumonia, that is the inflammatory process in the lung, or subcutaneous tissue inflammation or cellulitis. Tuberculosis, that is a common disease in our part of the world, is one of the chronic disease. Rheumatoid arthritis and chronic peptic ulcer are other examples of the chronic inflammatory diseases. So what causes chronic inflammation? So causes of the chronic inflammation can be classified as persistence of infection, hypersensitivity disease, prolonged exposure to toxic agents, and inflammation in non-traditional diseases. In these settings, chronic inflammation occurs when the microorganism is not easily eradicated. It may lead to body's prolonged response toward the microbe. The example for these are Mycobacterium tuberculosis, certain virus, fungi, and parasite. In some of these conditions, especially the Mycobacterium and fungi, they take the form of a specific pattern of chronic inflammation, that is chronic granulomatous disease, that we will study later. Then hypersensitivity diseases are also a setting in which chronic inflammation occurs. There is excessive and inappropriate immune activation, including the autoimmune and allergic diseases. So the example of these are rheumatoid arthritis, multiple sclerosis, inflammatory bowel disease, and bronchial asthma. When there is prolonged exposure to toxic agent, the inflammation occurs in chronic form. This toxic agent can be endogenous or exogenous. When inhaled silica particles are taken into the lung, they induce the chronic inflammation, chronic form of the inflammation, while the endogenous agent such as cholesterol may induce chronic inflammatory process. In some of the condition, the chronic inflammation is implicated. These are not typically classified as inflammatory. Either these are degenerative or metabolic diseases. Alzheimer's disease, in which there is deposition this is one of the neurodegenerative disease in which amyloid proteins are deposited. Then metabolic syndrome, type 2 diabetes, that is a pro-inflammatory state, and we know that inflammation driven tumor development is also a concept in carcinogenesis. So we can present these causes in a different way. So what are the causes or signals that lead to an extended response? These can be bacteria, viruses, parasites. Then the apoptosis, the neutrophilic apoptosis may also lead to chronic inflammation. The defective gene signaling, trauma, cancer, and immune factors, all these are the signals that are responsible for the chronicity of the inflammation. The bacteria, viruses, and parasites are persistently present. They are difficult to be removed sometime, and they result in chronicity. Then apoptosis. We know that neutrophils have got a specific way of degradation, that is netosis, and they form neutrophilic extracellular traps or nets. So that invite more of the uh, cytokines and invading agent. Then defective gene silencing. The gene silencing of the pro-inflammatory genes, they are not silenced, so there is persistence of the inflammation. If there is extensive tissue damage, that release more mediators, and the release of more mediator will prolong the response. Macrophages and T cells, T lymphocytes, are recruited by the tumor to feed and stimulate the tumor cell growth. Then there are some immune factors that are associated with the chronicity, and they are responsible. They are the antibody dependent and cell mediated immunity that is activated. What are the events that occur during this process? The events can be enumerated as specific triggers, chemical mediators, inflammatory cells, the interaction of DAMP and PAMP, that are the damage associated molecular pattern and pathogen associated molecular pattern with pattern recognition receptors, and stromal cell activation and extracellular matrix. The initiation of the response is by specific triggers that are microbial product or injury that initiate the inflammatory response. Then role of the chemical mediator is to recruit and activate inflammatory cells. The coagulation and complement, they generate the peptides that prolong the inflammation, while cytokines such as interleukin-6 and RANTase, they switch chemokines signals to recruit mononuclear cell. This rantase is regulated upon activation. Normal T cell expressed and presumably secreted. This is the abbreviation for this rantase. Then gamma interferon promote macrophage proliferation and activation. Inflammatory cells are also involved in this process, and these inflammatory cells are recruited from the blood. Macrophages play central role in the activation of the other immune cell and fibroblast. Then the damage associated molecular pattern and pathogen associated molecular pattern derive inflammation. They increase the activity of the inflammatory mediator. There is in their interaction with the pattern recognition receptors, and this sustains the inflammatory response even after the initial trigger is gone. Then tissue remodeling and fibrosis is through the stromal cell activation and extracellular matrix remodeling that influence the immune response. The extent of this fibrosis depends on tissue injury severity and persistence of the inflammation. So in contrast to acute inflammation, the chronic inflammation is characterized by infiltration with mononuclear cells. There is tissue destruction and there is simultaneous attempt at healing. We have seen these three elements in the definition of the inflammation, chronic inflammation also. So there is infiltration by macrophages, lymphocytes and plasma cell. There is extensive or limited tissue destruction with simultaneous attempt at healing that is characterized by angiogenesis and fibrosis. The histopathological appearance or these morphological features are seen in this histopathology. There is destruction of the parenchyma. There is simultaneous attempt at healing, and there is infiltration by mononuclear cells. So the morphological features of chronic inflammation are evident in this picture, that are chronic inflammatory cell collection, destruction of the parenchyma, and there is replacement by connective tissue or fibrosis. Now compare this picture with this one. This is showing what? This is showing acute inflammation. In this picture, in this one, there is infiltration by mononuclear, not mononuclear cells, by neutrophils. There are these neutrophils that are filling the alveoli, and also you can see that there is engorgement of the blood vessel. That are the characteristic of the acute inflammation. Although the macrophages are the predominant cell variety of the chronic inflammation, but they play in concert with lymphocyte and other cells, other subsets of the T lymphocytes and other cells, and there is armamentarium of cytokines and lymphokines that are associated with the this mechanism. So macrophage are the dominant immune cells in chronic inflammation. They are responsible for cytokine secretion, destruction of the pathogen, and activation of other immune cells such as T lymphocyte. They have got professional phagocytosis role as they filter microbe, debris and senescent cell while eliminating the pathogen. They are a permanent member of the body and body policing system, and they form mononuclear phagocytic system or reticuloendothelial system, and they are specifically present in some tissues to continuously filter out the invading agent or the damage that occurred to that particular tissue. When they are present in the liver, they are termed as Kupffer cell. Sinus histiocytes, when present in the spleen and lymph nodes. Microglial cell in central nervous system, and in lung they are termed as alveolar macrophages. They are derived from hematopoietic stem cells in the bone marrow and from yolk sac and fetal liver progenitor during embryonic development. Circulating monocytes, they can migrate into tissue and differentiate into macrophages under the inflammatory condition. The lifespan of the blood monocyte is about 1 day, while in the tissue they can stay alive for months to years. In inflammation, the monocyte migrate into the inflamed tissue within 24 to 48 hours, and they become predominant cell type after the 48 hours. And the extravasation of these monocytes into the tissue, it is regulated by adhesion molecules and chemokine mediators. So the role of macrophage can be summarized as dominant cell type, secretion of cytokines and growth factor, the specific phagocytic activity, and they are the key determinants of the outcome by the release of various substances. So whenever there is chronic injury or infection, it can lead to bacterial and tissue-derived monocyte chemotactic factor liberation. It can also activate T lymphocyte, and tissue-derived mitogen can also be secreted. So these chemotactic factor will recruit monocytes from the blood. Activated T lymphocytes will release chemotactic factors and growth factors. The chemotactic factors are responsible for the further recruitment of circulating monocyte, while growth factors are responsible for proliferation of tissue macrophages. All these effects cumulatively, they will lead to increased macrophage population in the tissue, and these macrophage population in the tissue are long lived. So the final outcome is the chronic inflammation, and this chronic inflammation has got the major dominant type of inflammatory cell, that is macrophage. Sometimes these macrophages, they cannot be eliminated, or they cannot be, they are, they have got increased role. Either they cannot eliminate the damaging agent, or they have got persistent role, so they attain the secretory activity. And like epithelial cells, these secretory activity, due to this secretory activity, they are termed as epithelioid cells. Epithelial like cells, as are seen in the granuloma. So the macrophages that are derived from bone marrow, they have got a single lobed nucleus. Inside the macrophage, you can see some phagocytic vacuole and some lysosomes also. So this kidney-shaped nucleus, and they are differentiated from the monocyte that exits circulation and become resident macrophages in tissue. Then they have got a specific name. The resident macrophages have got a specific name in the specific tissue. So these macrophages are important in acute and chronic inflammation both. In the acute inflammation, they migrate to the site of injury, clear pathogen and debris and apoptotic cells. In the chronic inflammation, they regulate the progression and maintenance of the inflammation. The function of these cells are phagocytosis, chemotaxis, antigen presenting processing, and immunomodulation. By the release of a battery of enzymes, cell mediators that are the inflammatory mediators, they are responsible for phagocytosis that engulf pathogen, dead cell and debris. Then they are also responsible for chemotaxis that means that they move toward the inflammatory signals, and they are responsible for antigen processing and presentation and activate T lymphocyte. Then various immunomodulatory factors are released from these macrophages that regulate immune response. A variety of receptors are expressed on the surface of these macrophages that are responsible for signaling. So these signaling can be in association with polymorphonuclear neutrophils, or some of the receptors are macrophage specific only. This picture is showing the maturation of mononuclear phagocyte. Here we can see that this uh, resident resident tissue macrophage that has got a specific name in many of the tissue, is derived from yolk sac in the early embryonic life that form this single lobed kidney shaped nucleus content of the macrophage, resident macrophage, and then the hemopoietic stem cell give rise to monocyte, and these monocyte can be used to replenish the decreasing number of the macrophage, or when there is inflammation present in the body, they are transformed into macrophages into the tissue. They are recruited from the circulation and they are transformed into the resident macrophages, where they are actively involved in both the acute and chronic inflammation. In this circulation, they have got the half life they have got the lifespan of only 1 day, while in the tissue they can live up to weeks or months. This picture is showing a monocyte bean shaped or kidney shaped nucleus and the activated macrophages. These activated macrophage is showing increased activity within the cell cytoplasm, a bit larger in size, and nucleus is opened up, have got more synthetic activity. Under the influence of macrophage colony stimulating factor or granulocyte monocyte colony stimulating factor or CSF colony stimulating factor 1, the monocytes are transformed into macrophages, and in the presence of interleukin gamma interferon, lipopolysaccharides, and in the presence of tumor necrotic factor alpha, they are transformed into classical or M1 type of macrophages that has got more tendency toward the inflammation, pro-inflammatory tendency. They promote Th1 response, they present antigen, they to a little extent they promote wound healing, but they are majorly they are involved in production of reactive oxygen species, reactive nitrogen species. They have got upregulated lysosomal enzymes. Also, interleukin 12, 23, tumor necrotic factor alpha, interleukin 1 and interleukin 6, along with various chemokines, are also secreted from type 1 macrophages or M1 classical macrophages. Under the influence of interleukin 4 and interleukin 13 that is produced from the T lymphocyte, there is activation of these macrophages into another state, that is M2 state or alternate type of macrophages. They are responsible for promotion of the Th2 response. They are present in tumor association. They produce interleukin 4, 10, transforming growth factor beta, various growth factor, platelet derived growth factor, vascular endothelial growth factor, epidermal growth factor, arginase, and there is association with angiogenesis, activation of fibroblast, and as a result collagen synthesis that is responsible for the uh, scar formation. So interleukin 10 and transforming growth factor that are released by this M2 or alternate macrophages, they promote resolution of the inflammation or can switch. If they are not activated, there can be switching from acute to chronic inflammatory state. This means that macrophages are multifunctional. So if we further specify, the microbes or gamma interferon, they will activate the pro-inflammatory or classically activated macrophages or M1 type of the macrophages, while the interleukin 13 or interleukin 4 are going to activate the M2 or alternate type of the macrophages. The classical activated macrophages are pro-inflammatory, and this action is through the reactive oxygen species, reactive nitrogen species, lysosomal enzymes that are responsible for microbicidal action, phagocytosis, and killing of many bacteria and fungi. While interleukin 1, 12, and 23 along with chemokines are responsible for the further uh, further amplification of the inflammation. While these M2 or alternate type, they liberate various growth factor and transforming growth factor beta that are responsible for tissue repair and fibrosis, while interleukin 10 and transforming growth factor beta applies brake to the inflammatory process. The diverse function of the macrophages can be grouped into inflammatory, non-inflammatory, effector, and accessory functions. The inflammatory functions are through the cytokines and chemokines. The important cytokines are interleukin 1, interleukin 6, TNF alpha, and arachidonic acid metabolites are also uh, implicated in inflammatory functions of the macrophages, while the effector functions are through metalloproteinases, nitric oxide, the oxidative bursts that occur during the process of phagolysosomal interaction, and then phagocytosis. Accessory functions are antigen presentation, co-stimulatory membrane ligand, that is CD80, and co-stimulatory cytokine, that is interleukin 1. The anti-inflammatory functions are through the molecules that are interleukin 10 and transforming growth factor beta, and also by interleukin 1 receptor antagonist. The lymphocytes are the another cell that are associated or that are considered as cell of chronic inflammation. They are about the size of red blood cells. They have got a large nucleus and sparse endoplasmic reticulum, having few lysosomes also. The characteristics of this cell are that they are associated with chronic inflammation. They have got key role in the humoral and cell mediated immune response. They produce cytokine that are termed as lymphokine, and they have got multiple subtypes. They are B cells, and these B cells are they are converted into plasma cell whenever there is activation, and these are responsible for the production of the antibodies. Then T cells can be divided into two major subsets. The effector, these T cells are processed in the thymus, while the B cells are uh, processed in considered to be processed in bone marrow. Then the T cells, they are effector cells and regulatory cells. The effector cells of T cells, they are involved in delayed type of hypersensitivity, mixed lymphocyte reactivity, and they also are involved in cytotoxic activity, and these are termed as cytotoxic T cells or CD8 cells, while regulatory cells or regulatory T cells are helper T cells and suppressor T cell. Then there are some cells that have got no marker on these cells. They are called as null cell. One of the subset of these null cell is called natural killer cell or NK cell. These natural killer cell or NK cells are involved in direct cytotoxicity or cellular destruction, as happens in viral infections, and they are also an important member of immune surveillance system. The lymphocytes are dominant cell in chronic inflammation. The antigen stimulated cells, the effector and memory B and T cells, they interact with various adhesion molecules and their ligands, adhesion molecules such as selectin, integrin, and also with various chemokines, and they move toward the site of inflammation by the mechanism of chemotaxis. Macrophages at the site of inflammation, they also secrete chemokines, interleukin 1 and tumor necrotic factor. These are responsible for recruitment of more lymphocyte at the site of the inflammation. CD4 lymphocyte have got secretory activity. They secrete more cytokines, CD4 type of the T cells. They secrete plenty of cytokines, and this promote inflammation and also influence the nature of inflammatory reaction. There are three subsets of CD4 T type of the lymphocyte. These are Th1, Th2, and Th17. The three sets of these T helper cells are Th1, Th2, and Th17. Th1 secretes interferon gamma, and this activates macrophages by classical pathway, while Th2 response is associated with the secretion of interleukin 4, 5, and 13, and they are responsible for the macrophage activation by the alternate pathway. However, it is also associated with the eosinophil recruitment and activation. Th17 response is associated with with the interleukin 17 secretion, and this is associated with the recruitment and activation of neutrophils and monocytes. The Th1 and Th17 response is an important component in the bacterial viral diseases and also in autoimmune diseases, while the Th2 response is important in helminthic parasite infestation and allergic inflammation. This picture is summarizing these events. Here you can see that this T lymphocyte, when it is activated, the Th1 and Th17 subset of these T lymphocyte, when activated, there is secretion of interleukin 17 that is responsible for recruitment of neutrophil and monocyte, and there are obviously other inflammatory mediators that are also released from these activated subsets of T lymphocyte. And another another cytokine that is secreted from these activated T lymphocyte is interferon gamma, and these gamma interferon is responsible for the activation of macrophage through classical pathway. So now the pro-inflammatory macrophages are activated, and these activated macrophages further they secrete cytokines that are pro-inflammatory, such as interleukin 12, interleukin 6, and interleukin 23, and these activated macrophages, the classical macrophages, they also secrete tumor necrotic factor, interleukin 1, and chemokines. So further, they recruit neutrophils and uh, macrophages to the site of the inflammation. This illustration is showing the macrophage lymphocyte interaction that are bidirectional and co-stimulatory. Uh, the activated T lymphocytes secrete cytokines such as TNF and chemokine that recruit leukocyte and monocyte from the circulation. The monocyte, under the influence of gamma interferon that comes from the CD4 T cells, it activates the macrophages, and now the macrophages are activated. They secrete interleukin 12 that in return stimulate the T cell, and also these activated macrophage present antigen to the T cells. When these are not potent enough to clear the damaging agent, there is formation of the granuloma, that is the accumulation of epithelioid cells, the macrophages that are transformed and have got more secretory activity and resembling like epithelial like cell, and some of these they merge together and form giant cell. This area is confined by a thin rim of the fibroblast, so fibroblast rim is there, and a thin rim of lymphocyte also surrounds this granuloma, along with activated macrophages. Another cell of chronic inflammation is plasma cell. The plasma cell is associated with antibody production and secretion, and it is derived from B cells. So there is, due to the secretory activity of immunoglobulin, there is increased endoplasmic reticulum and prominent Golgi apparatus, and the nuclei are opened up. The nucleus is opened up with peripheral chromatin within the nucleus that gives the appearance a clock face appearance or cartwheel appearance. Classical uh, description for the plasma cell, histologic description for the plasma cell. The activated B lymphocyte and antibody producing cells, uh, plasma cells, are often present at the site of chronic inflammation. These are basically B cells that are producing antibody, so they are termed as plasma cells. And these antibodies that are produced by plasma cell, they invade and target the foreign antigen, self antigen, or altered tissue component. Their role in the chronic inflammation is due to their presence at the sites of persistent inflammation. They contribute to autoimmune and chronic inflammatory disease also, and there they target persistent and self antigen, persistent pathogen if there is lying any pathogen persistently, or may target self antigen. So in many of the conditions there are presence of clusters of lymphocyte antigen presenting cells and plasma cells like in lymph node. They resemble like lymph node, and hence they are termed as tertiary lymphoid organs. So this condition, these structures are usually seen in rheumatoid arthritis, in the synovium, and in the Hashimoto thyroiditis. Eosinophil is another cell of inflammation, and it has got various characteristic and function. It is associated with allergic reaction and parasite associated inflammatory reaction, and also with chronic inflammation. It modulates mast cell mediated reactions. So it has got some reactive oxygen metabolites, and also there is lysosomal granule enzymes, many of the lysosomal granule enzymes, and they contain primary crystallite granules of major basic protein, eosinophil cation protein, eosinophil peroxidase, acid phosphatase, beta glucuronidase, aryl sulfatase B, and histaminase. Also contain phospholipase D, prostaglandin of E series, various cytokines, and leukotriene and platelet activating factor. They express IgA receptors and these eosinophil basic major basic protein. Both of these are associated with uh, parasite associated inflammatory reactions. So eosinophils have been implicated in IgE mediated immune reaction and parasitic infection. They express various adhesion molecule, and simultaneously there are chemokines, especially eotoxin for eosinophil, and other ligand are expressed on the epithelial cell. The epithelial cell and leukocyte. These chemokines are responsible for their adhesion, and whenever they bind, there is their start of their degranulation, and degranulation of these eosinophil is responsible for the tissue injury and the destruction of the parasite also. This photomicrograph is showing the eosinophils that are present in an inflammatory reaction. Some of these have got are degranulating their content outside, and some have got intact membrane. Another important cell in the chronic inflammation are mast cell and basophils. The basophils are the least common leukocyte that are present in the blood, and they can migrate into the tissue to participate in immunological response. They bind with the IgE molecule, and they bind with IgE molecule, and these cells, these mast cells, they have got electron dense granules. They are present in connective tissue, lung and JIT surface, dermis and microvascular vasculature also, and they are very important in regulating vascular permeability and bronchial smooth muscle tone. So whenever in tissue, they are long lived, and especially they are the cell of hypersensitivity reaction, immunologic reaction, allergic reaction, or hypersensitivity reaction. Whenever they are stimulated, they have got some important inflammatory mediators such as histamine that binds with H1 receptors, and this H1 receptor binding will result in vasodilation due to many effects such as the increase in the vascular gap that results in edema. So edema or vascular permeability can be controlled by H1 receptor antagonist. Then it has got leukotriene C, D, and E, platelet activating factor, eosinophil and neutrophil chemotactic factors that attract more eosinophil and neutrophil toward the site of their degranulation, serine proteases, heparin, and various cytokines such as TNF and interleukin 4 are also released. Mast cells express Fc epsilon R1 receptor on their surface, and these receptors are receptor for Fc portion of IgE antibody. Whenever there is interaction of IgE antibody with Fc epsilon R1 receptor, the mast cell degranulate, and there is secretion of plethora of enzymes that result in uh, either a trichuria, or that is a localized reaction, or severe systemic reaction, that is anaphylactic shock. So the condition that causes this state are allergic reaction to food, insect venom, and various drugs. Neutrophils are major culprit in acute inflammation, but they can be seen in the chronic inflammation if the stimulus is persistent and the mediator produced by activated macrophages and T lymphocytes. The condition can be seen in osteomyelitis. In this condition, for months there can be presence of neutrophils that are associated with the damage, and neutrophilic exudate can be seen on biopsy. And then the lung damage by smoking is another example of the presence of neutrophils in chronic inflammation, and in such conditions these can be named as acute on chronic inflammation. A link between the cancer development and inflammation, especially the chronic inflammation, has been developed. Some examples that lead to this cancer are schistosomiasis, reflux esophagitis, and ulcerative colitis. How these turn into a tumor, there are many mechanisms. First, there is increased cellular proliferation in chronic inflammation, and this chronic inflammation and increased cellular proliferation creates a microenvironment that is favorable for malignant transformation. In schistosomiasis, the condition leads to squamous cell carcinoma of the bladder. The reflex esophagitis lead to esophageal adenocarcinoma, and ulcerative colitis lead to colorectal adenocarcinoma. The mechanism that promote are chronic stimulation, cellular proliferation, and increased risk of mutation and transformation of the cell into malignant one. And there can be oxygen and nitric oxide metabolites. These reactive metabolites can cause DNA damage and genomic instability. Chronic immune activation, that is the one of the feature of chronic inflammation, is characterized by altered cytokine balance, and this altered cytokine balance suppresses cell-mediated immune responses and reduce cancer surveillance. Then there is angiogenesis in chronic inflammation. There is more new blood vessels are formed. There are increased number of new blood vessels that support the tumor growth. And finally, there is inhibition of the apoptosis, and this apoptosis, when inhibited, it allows mutated cell to persist and proliferate. Thereby, they promote malignancy. Now, to understand the concept of chronic inflammation, we will see some case scenarios and their explanation. In this case scenario, a 35-year-old woman presents with morning stiffness and symmetric joint pain in the hand and wrist for 6 months. Lab shows elevated rheumatoid factor and anti-CCP antibodies. So this is a chronic inflammation, and there is involvement of the synovium that overgrows on the cartilage surface of the joint, that is called a pannus because it engulfs the cartilage like an apron. And due to T cells and cytokine activation such as TNF alpha, interleukin 1 and 6, there is destruction of the cartilage and bone. If untreated, the rheumatoid arthritis will lead to deformities of the joint and disability. So anti-TNF therapy such as infliximab and etanercept are target inflammatory pathways. Now, here is another example of chronic inflammation. A 28-year-old man presents with bloody diarrhea, abdominal pain, and weight loss. Colonoscopy reveals continuous colonic mucosal inflammation with crypt abscess. So there is chronic inflammation in ulcerative colitis that is limited to mucosa and submucosa only, in contrast to Crohn's disease that involves the whole of the gut lumen wall, gut wall. And this chronic inflammation is mediated by Th2 cytokine response, in which the T interleukin 4, 5 and 13 are secreted, and the recurrent inflammation in this condition increases the risk of colorectal adenocarcinoma. The long-term surveillance is needed to control or to supervise the high colorectal adenocarcinoma risk that is associated with this disease. Then there is another example, a 50-year-old man with history of chronic gastroesophageal reflux disease complains of worsening heartburn. Endoscopy shows columnar epithelium that replaced squamous epithelium in the lower esophagus. There is persistence of acid reflux that causes metaplasia. In the metaplasia, the squamous epithelium of the lower esophageal part is transformed into columnar type and there is formation of goblet cell. This also increases the risk of esophageal adenocarcinoma, and patient of these condition they require endoscopic monitoring along with PPIs, proton pump inhibitors. Then a 42 years old intravenous drug abuser presents with fatigue, jaundice and hepatomegaly. Lab tests reveal elevated ALT, AST and positive HCV RNA. Liver biopsy showed bridging fibrosis. So there is fibrosis, destruction and virus. So this persistent viral replication is cause of chronic inflammatory cell infiltration, hepatocyte necrosis and progressive fibrosis, and this is T cell mediated response as happen in viral conditions. So the chronic hepatitis can lead to liver failure and hepatocellular carcinoma. So antiviral therapy is needed. Another scenario in which a 60-year-old man with hypertension, diabetes and high cholesterol present with chest pain. Angiography revealed narrowing of the coronary artery. The pathological basis of this condition is the lipid accumulation in the vessel wall that lead to activation of macrophages, foam cell formation and cytokine mediated plaque development. And if there is chronic inflammation, it will lead to plaque instability and finally myocardial infarction or stroke may ensue. Statin use may reduce inflammation and slow disease progression. Then a 40 years old woman with fatigue, weight gain and cold intolerance has an enlarged firm thyroid. Lab tests show high TSH, low T3, T4 and anti-TPO antibodies. So what is the pathologic base? The autoimmune attack by CD4 cells lead to chronic inflammation that destroy the follicular architecture of the thyroid. There is fibrosis and as the thyroid tissue or parenchyma is destroyed, there is loss of function of the tissue, that is hypothyroidism. Patients require a lifelong thyroid hormone replacement therapy and there are increased chances of B-cell lymphoma. Then a 10-year-old boy with a history of bone pain and fever presents with a tender swollen tibia. X-ray shows a sequestrum, that is a necrotic bone. The persistent bacterial infection, often Staph aureus, lead to inflammatory cytokine release, necrosis and formation of dead bone that is termed as sequestrum, and this dead bone is surrounded by involucrum or reactive bone formation. This patient requires long-term antibiotic or surgical debridement. if not treated properly, can lead to deformities or formation of a sinus tract. A 55-year-old man with epigastric pain, worse at night and relieved by food, has H. pylori infection. Endoscopy reveals chronic gastric ulceration with fibrosis. So the pathologic basis is that the H. pylori infection and non-steroidal anti-inflammatory drug use lead to recurrent mucosal injury, inflammation, and delayed healing due to inflammatory cytokines and impaired mucosal defense. So there is increased risk of gastric carcinoma and perforation. H. pylori eradication and acid suppression are needed. Then a 55-year-old minor presents with progressive dyspnea, chest X-ray show upper lobe nodular opacity and biopsy reveal silica-laden macrophages. So there is chronic exposure to silica that lead to macrophage activation, fibrosis, and stiffness at the lung. Silica-induced inflammation persists due to inability to clear the particles. Then this increased risk of pulmonary fibrosis, respiratory failure, and tuberculosis are associated with this silicosis. No cure is available. Prevention is only the key for the silicosis. Thank you for watching this video. If you have any query, please write in the comment box. Thanks.